Okay, I think we're ready to bother Dr. Metzer again. Dr. Metzer, are you there?
I am. Can you see and hear us okay?
We can see you and we can hear you well. This is Daniel Hahn from Mount Sinai. I'm joined by an amazing mixed kind of specialty group with us. We have Dr. Anvar Babayev, Dr. Christian Bianchi, Dr. Sanjay Desai, Dr. Jay Matthews, Dr. Jose Wiley, Dr. Zeller, and Dr. Kumar Madassari, who are all here to watch you do your work for us.
Fantastic. Well, listen, welcome back to Columbus. We were supposed to do a long CTO for the first one. We had to do a little rearranging, but hopefully you'll get your money's worth out of this, and we'll need all your help. Before we get started, I want to introduce the team that does amazing work, and they really moved to get this one ready because there was a lot to get ready. To my right, superstar friend and great operator Michael Jolly. Behind us, actually, the hardest job, Liz, is going to control Jolly and Metzger. She has the hardest job in the world. Behind, we have Corinne. We also have over here Michelle and Jed, and an entire team who's really worked hard, including some industry friends as well. So, again, welcome to Columbus in OhioHealth Riverside. All right, let's go to our slides. We got a challenging case for you here. All right, next slide, please. And these are disclosures, or mine and Michael's. His list is going to get there next. All right. Very pleasant gentleman, young guy who had severe coronary disease, 6-vessel bypass in March of this year. We met him actually at a left subclavian stenosis as well, and we were going to fix a left subclavian before his bypass, except it was right around it was both pre and post a vertebral artery which had disease, and the lima itself had osteal disease by IVUS. So instead, we left that alone. It was asymptomatic, and they used a free lima during his bypass. He happily discontinued tobacco then, and you see his other risk factors. He's non-diabetic. He actually had significant carotid disease that, in fact, Dr. Jolly treated as a live case for Link, and I was monitoring from Germany, so we were across the pond in connection here on that, and when he did very well with that. He's been in cardiac rehab and doing everything correct, and he has severe claudication at short walking distances. They've got him on maximized medical therapy, silastazol, dual antiplatelet therapy, statin, et cetera, and he had literally a supervised walking program, not just talking about it. He was in cardiac rehab and supervised walking, and really can't walk very much. And then he has some rest pain intermittently now, but does not have rubor or an ulcer. Next slide, please. ABIs are low and drop with exercise, and it lasted 10 minutes in the post-exercise period. Duplex had some moderate inflow disease, and then had occlusion of the right SFA, and the entire anterior tibial was occluded throughout its length. CT angiogram had an interesting interpretation. It said normal SFA without significant stenosis. We'll see if you agree with their interpretation when we show you some angiograms, but also had some common iliac artery, ectatic disease, and then had really hard to tell what was going on in the popliteal until we saw it yesterday, and you'll see it together with us today. Vein mapping was very poor, remaining venous conduits after his extensive bypass surgery, and so he's here for angiography and intervention as appropriate. Next slide, please. So in summary, a very pleasant 66-year-old gentleman, bypass, former tobacco happily resolved, and here with severe symptoms, refractory therapy for us to work on. Next slide. All right, let's go to our fluoro, please. Okay, let's go to our fluoro. There we go. All right, so like everybody, we use vascular ultrasound, micropuncture access, allows you to get right in a good spot. And you'll notice, by the way, a little bit of disease in the distal left common femoral artery that we were able to avoid with ultrasound. Renals, moderate. You can see the ectatic plaque in the common iliac arteries bilaterally. A little bit ulcerated as well on both sides. That's an adventure for another day. But there does look like room for covered stents later as needed. Very carefully, we brought an ansel across, and here's our pictures. So this is a pretty steep RAO to get the, you can see the big hypertrophied profunda, kind of a diffusely diseased SFA. And then we're going to come down here. And here's pretty interesting. It occludes there. And I want you to look at that for a little bit, because this is a scenario above and below, as we found out all too well, that there's a lot of branches you have to uncover. Here, we'll take this with a little bigger mag, and you can see at the top a straight line there, and then you can see the reconstitution of the SFA. Now, as we come down, the popliteal artery, you can see the collateral's already here. The popliteal is okay, but watch what happens distally. And even with our pictures yesterday, we did a lot of pictures yesterday. You really had to take a lot of angles to find out what's going on there. And I'm going to let that play. And you can see there how it reconstitutes right above the perineal PT bifurcation. Again, the anterior tibial is out its entire length. So is the TP trunk. And then and you can see that little tiny remnant of an almost recanalized pop that you can see there, right here. Okay? And we'll show you that as well. We'll go down the leg, and what you'll see is that there's two vessel runoff via the perineal and posterior tibial artery, the rest of which are pretty good. And there's the foot. So with that, couple questions here. If he had wounds, we'd for sure be obligated to fix everything. We would probably be more inclined to fix everything today. He has severe claudication at minimum walking distance. He has some rest pain. And so thinking of that, we've got the SFA occlusion, all right? And then we've got a popliteal and TP trunk occlusion. And think about the strategy here. And again, here's just another picture showing that kind of obliterative looking distal pop right here that we've seen there. That's not, by the way, the pop there. That's an overlying collateral that you'll see in other vessels. So, so thoughts from the panel here. First of all, should we just fix the SFA today? We've got natural distal protection with an occlusion, okay? And then see how he does and stage the other. Do we cross both of them, fix both of them, and in which order? And finally, if we're going to fix both of them, how would you cross the TP trunk occlusion? So let me get an opinion or two, and then we should probably get to work, but I've been talking for a while. So one lesion or two, all antegrade, combined, what do you think?
We'll do a little poll for you. Can I get the panelists? One lesion? Two lesions? It's unanimous. Two lesions, Dr. Messer. They want to see you do some work. And then I want to get...
I was afraid we wouldn't get off the hook.
Do any of the panelists have some opinions?
All right,
about
now,
I don't.
I think the technical challenge of that island and then the distal makes it a retrograde approach from the beginning.
Yeah.
Probably the caveat is at that bifurcation TP trunk, your wire may actually go into the perineal a lot, so you got to orient it. But I think I will start with a two antegrade and retrograde approach.
And I think we got a little, like, kind of a sneak preview of what Dr. Mitzer is doing. But from above, it looked like there was giant collaterals. And right at the end of that SFA, there's a huge branch that's coming off at that area. So it might be even difficult to engage from above. So to your point, just engaging from below from the start might actually make it easier. Not saying this is an easy case by any imagination. But it sounds like retrograde, treat both, Dr. Metzer. This is kind of what the panel is thinking.
all right, you slave drivers. That's Michael and I. We were going to do one, but we thought, I know who's on this panel, and you guys are not going to let us off the hook. That's fine. So so you can see that roadmap that I'm showing you there. And one of the nice things is trying to put point A to point B, and you can see that little line there. And we were actually able to cross that. I guess the fluorosave didn't take. And here's our picture with a catheter through that. We had a little team debacle where we pulled it out just to see, and we did it again. So we were 2 for 2. So now, to everybody's point here, that is an island. That's exactly the word you used, Michael. Yeah. And when we thought about if we're going to treat this, the last thing we want to do is take it down past that PT tibial bifurcation. So what we did, or let me just rephrase that, what Dr. Michael Jolly did was got PT access in less than 1 minute. You want to tell them how you do that with ultrasound?
Put the ultrasound on, stick the artery.
Right,
That's pretty.
All right.
Just like that.
And then we really had to work this. and these young guys make it look so easy too, by the way. So then we came retrograde and we're able to cross this, not easily, by the way, but you can see our wire there,
What devices did they use?
working our way up. This was a Command 18.
Yeah, Command 18. There was some, it was pretty gritty in there. So there may have been some subintimal midway and then in and out. It's pretty calcified, but it wasn't too challenging, thank goodness.
Yeah. And so that was, and then we combined efforts. Mine was in part where I steered that catheter from above exactly where his wire was from below. And then we've externalized, so we're through and through. Now, there's a lot of ways to do this. We think that we're going to at least go ahead and treat the inflow stuff in the SFA with this natural protection system of an occlusion, fix that, and then we're going to see what to do with the distal lesion. Obviously, there's a lot of ways that we could do that. Do me a favor, Liz, if you'll hold this wire, please.
And Dr. Metzer, while you're working on that a little bit, I think you made this wire cross look so quick and so easy, but I think for a lot of the audience members, how long do you try from above before you switch to this retrograde attempt? I know some of our panelists were already saying jump down below, kind of from the get-go. How long do you try from above?
It depends on what the wire feedback. What do you think, Michael?
Yeah.
I mean, I think it really depends on the wire feedback. And we didn't even try antegrade through that island.
No. For the popliteal, you could see the way it reconstituted. There was no reason to try from above because if you get subintimal, you're potentially going to lose your PT or your perineal. I think I could probably convince you most of that. For the SFA, we crossed to antegrade and it wasn't too challenging. But because we're retrograde anyway, we have the option to do either, even if we have to kind of cart or re-enter. But because it occluded, it came back online right at the bifurcation. I think crossing that retrograde as a de novo strategy was the way to go.
Okay, so can I ask the panel now while they're working,
Looks downstream.
with the wire cross, what are people thinking for treatment? What would you guys like to see?
Do we think this is heavily calcified, at least from the CT perspective? Is that why they thought it was a patent vessel? I mean, IVUS would probably help to know what we're dealing with inside there if you're planning a vessel prep.
Dr. Metzer, do you hear that question from Dr. Madasseri?
Yeah, so we're planning vessel prep here. And what we're going to do, this is a scoring balloon. This is a 6x120 chocolate balloon. And the idea there is that often, if we're going to get a nice lumen without dissection and offer DCB, that's what we would do. We had to wire this twice, and I didn't really like the idea of atherectomy, and especially we don't want to give up our wire. We would use distal protection with that and so on. So we really are going to go with a strategy of chocolate balloon long inflations. I'm a little concerned on that second look on that little roadmap that we may have re-entered in a subintimal plane. We're clearly in a true lumen for sure, but we'll be prepared with coverage stents and such if we need to. So this is just a chocolate balloon.
Is that your pre-angioplasty choice for all DCBs? We had a talk right before this about vessel prep for DCB and benefits of atherectomy versus IVL for vessel prep. Is the chocolate balloon your go-to?
It's one of them for sure. What I've found, and what was in the study as well, was there's no magic science about it, but what it does, in my opinion, is gives you a nice lumen with a low dissection rate. You saw in our first case when there was circumferential calcium, the same was true of the shockwave system. And so, go ahead, let's take that roadmap off. So it depends on what the anatomy, if there's calcium, this is not what I would use. I would use one of the other systems. Let's go up again. Sir, you may feel a little discomfort here, sorry. What do others there think for vessel prep? I like doing something more than balloon. I don't like to dissect it because then it doesn't give us as many options, I don't think.
Would any of the panelists have done atherectomy as vessel prep here prior to DCB?
Yeah, I mean, I tend to do debulking first before I'll use a scoring balloon or other type of specialty balloon. I don't go up front with a specialty balloon, especially if we know that it's completely chock full of material. You're going to just end up with more barotrauma, right? So that material has to go somewhere. If it's purely soft, it might be okay, but you sometimes, again, IVUS will help you understand.
If you say debulking specifically, what would you use?
I like laser quite a bit, but you can use anything really for this, some type of excisional atherectomy, but I use turbo power for this.
I mean, you don't see a lot of calcium there. I think you could use whatever you want. Directional atherectomy would be fine. Scoring balloon would be fine as well. IVL, I don't think so. I don't think there's much calcium there.
I think they were not sure. I think there was a comment there that whether they were subintimal at any point while crossing back into the proximal SFA. I think when you are not sure whether you are subintimal or not, maybe avoiding atherectomy is. I think I would personally avoid atherectomy when I'm not sure whether I'm subintimal or intralumen, and I would also try to do some sort of ballooning. Either seronator or chocolate balloon, and then see how the vessel responds to the balloon before I decide on the next step.
We have some comments from the audience as well.
Yeah, just a question actually. Chris, this is Stephen from Singapore. I just wanted to know, along the lines of the same question, do you think you were subintimal or intraluminal in the proximal segment? And if you were subintimal, do you think a scoring balloon would work as well in a subintimal plane as compared to an intraluminal plane?
Yeah.
Thanks.
It's a great question, Steve. I think, first of all, I am like Anwar. I don't like the idea, go up just gently to 3, maybe. I don't like the idea of atherectomy in a subintimal space. It just doesn't make sense to me. It's higher risk and less doing what the device would do. We were pretty comfortable here that we were in the true lumen in the proximal part. You know, roadmap, it behaved like that, it did that. We were a little pressed for time. Often we would ultrasound or IVUS, and we've got that hooked up later if it's the right thing to do. Notice that we're using a steep RAO, and we're going up very gentle here, Steve, at the ostium, so that we're not, you know, the others were pretty high. This one's not as high. Go up one more.
Yeah, I got you.
That's okay. Yeah. All right, come on down.
And Dr.
So
Metzer,
now
how are you
expanded.
sizing this?
So what we're going to do, yeah, go ahead.
How are you sizing this?
How are we sizing it? Michael and I, how are we sizing it? So this is 6. We think it's 5'5".
You did the other leg too.
I'm sorry.
You did the other leg too, right?
Yeah, you know, the other thing we had pictures of the leg, Michael just reminded me as well. So sometimes it's good to have continuity of care.
It's fantastic.
It's kind of the Jelly of the Month Club, the gifts that keep on giving.
There you go.
Can someone comment on atherectomy in the subintimal plane?
It depends on the device, right? So some devices are very dangerous to use in the subintimal plane. So I think, I mean, it depends also how subintimal you are. Right? If you're out in outer space, your perforation risk is going to be quite high, and I think you're going to end up putting a whole bunch of covered stents in. But if you're just immediately subintimal,
Towards you or away from you?
most of the atherectomy devices you can get away with. Like I said, I laser the subintimal plane all the time. There's no contraindication to it. You tend to ablate that tissue away, and it really doesn't necessarily increase your risk of restenosis. At least clinically, we haven't seen that. But again, IVUS is key because you have to see what you're left with. Do you have a big flap afterwards? I'll show a case later about that, but it'll dictate what you do, whether it be DCB or stenting.
I feel like we have similar kind of ideas about that, where like if you're in the subintimal space, people are probably not grabbing a rotational atherectomy device or an orbital atherectomy device. But I do have partners who like using a directional atherectomy where you think you cross back into the true lumen, aimed specifically at that direction, and it gives you some ability to do that, I guess.
I mean, you have to be really good to do that. That's the thing. So if you're really skilled, I think you can direct your atherectomy device in towards the lumen. But
It's the only the cases we see in an interesting case conference. You know?
right, exactly.
I think that all of us have used directional atherectomy in the subintimal space. I think you could direct a little bit better. The only issue is deep cuts and adventitious cuts that are associated with increased restenosis. PK proved that several years ago.
Dr. Messer, the luminal gain looks pretty good.
It does. Now, and honestly, this is let me just show that last picture again. I think the luminal gain looks great. And I think the part downstream that you see there is where I told you I thought we were subintimal. So that's not the fault of the chocolate balloon or whatever scoring balloon that you're using. That was the fault of Chris Metzger. And so with that reentry part, I really think we should stent that. I mean, the rest of it looks pretty good, and we could think about DC being that alone, and that would be reasonable. And then what I want to do is tack that up here, and then we're going to see what we want to do with the, I want you to start thinking ahead what we probably won't do if we're going to stent this out. We're not going to stent the ostium of the SFA with a nitinol drug-eluting stent yet, because we're going to have to do more work, and I don't like to go through the ostium of a nitinol stent. So I want you to think about what our strategy would be in the, remember that the popliteal was at island with the TP trunk occlusion. So let me get this here first, and let's smart map that.
Chris, do you always stent the reentry point?
You ready?
Keep going.
I like to. I really do. I think.
Gotcha.
I think it makes a big, and especially when you see that it's clearly subintimal here, or you know that just even on the roadmap that I showed you to begin with. You good, Mike?
Yep.
Now this is a little bit of. I like Superas. This one, I'm a short, old guy, so we're going to have to work on this one a little bit. But
so
I may have you hit view roadmap for a second.
Yeah, Chris, what do you think to hit that spot with the drug-coated balloon and then deploy superior, or it doesn't matter right now?
Yeah, it's a good question. I think that with a 6.0 Supera, the patency is so good that I don't think you have to. I think when we start getting 5.5s, and if I almost never put a 5.0 Supera. Let's go down towards that.
Yeah. Okay.
By the way, you may notice something they do extremely well, and I've learned since I've been in OhioHealth. What they do is they flip the room. So if you notice, we're working on the right leg, and instead of being under the eye like I've spent a long career, we're actually facing that away. And it's something they do very well and can do very quickly. So we're going to be aggressive, and I really believe that the bigger the interwoven stent, the better the patency. Now we weren't as aggressive sometimes with the pre-deal as we would, but I still think we're going to be aggressive enough to do a good job of this, I hope.
Hey, Chris, what length is that stent?
It's a 150. And we'll grab us, if you will, a 6.0. Anytime we see a little elongation like that, we're going to have to post-dilate, and we're going to really have to post-dilate that part, sorry.
Chris, Christian Bianchi here. Any experience with the Misago, another interwoven stent?
Yeah, I don't. I've been an early adopter of this one, and the experience has been so good and so durable. I've fallen in love. I have and I'm a faithful lover.
So Chris, it's
tell my wife that if you see her.
Chris, it's speaking. I just have one question for the panel too. I mean, everybody talked about stent avoiding technique. With best SFA, coming out with the 40% provisional, whatever it is, stent rate in the stent avoiding arm. I mean, why wouldn't we just put a drug-coated stent all the way up and say that we have randomized data that's shows a good result versus with the Supera stent, which I think in heavy calcium or a difficult complex lesion makes sense, but in a soft vanilla lesion like this, I'm just curious on the thoughts of why we'd want to avoid a stent versus place a stent.
There are so many ways to go around, and Tomas is on the panel. He's a very smart gentleman. He's, I think, a pretty big proponent of trying to avoid metal, and I think you can make a case either way. I really do. But I think that the interwoven stents do a very good job, and they don't fracture, so I don't feel as bad about doing them. Let's get that balloon open, please.
Tomas, what do you think?
Well, to be honest, in this kind of lesion, a DES
6x100
like Eluvia would make a perfect job. Today, these are the best outcome data, at least up to 1 year, which are published for this kind of lesions, confirmed just recently by the sports trial, which was comparing Eluvia with DCB and bare metal stents, including Supera, by the way, and it was clearly superior to both other strategies.
Hey,
Yeah, for Illuvia, in this case, without significant calcification would be the first choice. Yeah.
Bring a 60120, Saparan.
Can I ask one more question to Tomas? Tomas, what about aneurysm formation if you do a drug-eluting stent in a subintimal plane?
Yeah. Well, if
6x100
we
balloon.
see aneurysmal degeneration, then it's only in subintimal space. And here, in this particular case, I would have loved to see IVUS, to be honest. I'm not a IVUS promoter. I'm not known as one. But here, I was not fully convinced that it was a complete subintimal crossing. An angiographic appearance like this could also mean you crossed a thrombotic occlusion, because flow around thrombus looks very similar to what I've seen here in this angiogram. So I would have loved to see whether this is an intraluminal thrombotic angiogram or a subintimal. So this would have guided my decision. Yeah.
I hate to hog the microphone. Anvar, just one question. You said drug-eluting balloon before Supera. Any thoughts on why and experience?
I don't know.
No, it just, I'm a believer in, drug-coated devices, and to me it would make sense to put, to do my best to potentially improve the patency rates long-term. And I think getting the drug into the vessel wall potentially can help. Another thing is, I agree with Chris. I would definitely stent that area, because every time you deal with a relatively long CTO, and if you have the angiographic result as we get, as we saw in this particular case with some unhappy segments, I think every time you do IVUS of this area, you're going to see not just dissections, but severe, significant stenotic area still residual. And I think by stenting this area, you will sleep better, knowing that it's not going to acutely close, and hopefully gives you a better long-term patency.
Would anyone consider a shorter drug-eluting stent or interwoven stent than the rest with DCB?
Absolutely. Again, depends on what the average shows.
So you want to do that? I tell you what, let's do that. Let's take a 6x200 Ranger, please. Let's do that. Let's do a DCB in the proximal part. It'll be good vessel prep anyhow in case we implant a stent. And then we may not need to stent all of it. And then, Tomas, your point was very well taken. If we need to make a decision, we can use the IVUS that's already hooked up. And then we'll decide. Let's do that next part. And then, Dan, you let us know if it's better to go to a talk and come back to us, or stick with us for a little bit. We will follow your lead.
I think we have one more question, and then...
Yeah, no, it's just a comment we're together here. And another opportunity to do a DCB inflation, and then there's still a residual tech.
Sorry, DCB and then tacking?
I didn't hear.
Yeah, prolonged inflation, right, to mitigate that dissection. So to me, based on what I interpret, this was a primary stent.
Not yet. You got it? Not yet.
In my opinion, this is not a bailout.
Yeah.
He had that bias of.
Yeah, I think the bottom.
Dr. Fanelli's point is DCB, no stent, and then minimize the footprint by attack.
I think TAC's a great idea. I just worry about how aggressive that lesion looked up the proximal SFA with that dissection and the disease of degree. So I don't know. I mean, I think when you have a nice vessel with some flaps, the TAC works well. I think here, I think with Christian, if that's going to look like it needs a scaffold, just put a scaffold. We know it's going to do well.
Yeah. I think after the post-angioplasty with the chocolate balloon, if you looked at the flow, it looked pretty good for majority of it. It was just that one segment that Dr. Metzer ended up stenting that looked like there was abnormal flow. Was it thrombus? Was it intimal? Is it intimal flap? We don't really know because we don't have the IVUS information. But that proximal portion with DCB kind of makes sense. Dr. Metzer, then we'll leave you for a little bit. We'll do two talks, then come back to you. Does that sound okay to you?
Absolutely. Let me show you where we are right here, just with a roadmap. Go forward and stop. And then we'll do just what you said, Dan. I think that's perfect. So let me just do a roadmap. And what we're doing here is a 6x200 Ranger. Hit the roadmap button, please. And we're going to nail it at the ostium here, right there. And then we'll do prolonged inflations and keep working and then come back to you.
Thank you very much. Dr. Messer, can we go back to you? I think we saw you doing some work.
Go for it.
Yeah, please come back. So what we did, let me just go back a little bit here. When you left us, we took this picture here. I'm sorry, we did a DCB here, this 6x200 Ranger, and then we did this angiogram. And it doesn't look that bad. Now, Tomas, your voice was right in our ears with good advice. So we did the IVUS. So show the IVUS, please, next, if you'll show the IVUS.
This is in, going in.
And this is proximal to distal. Good call. We're not seeing the IVUS yet. Hey, Tim, if you'll show the IVUS to the audience in New York, please appreciate it. Let me know when you see the IVUS, please.
Yep, it's on our screen now.
Now, go ahead and play that, please. Yep, go ahead and play it, please. And, I think there's no question that some of that is subintimal. And not a small amount of the subintimal. And so with that, I think it tells us what our strategy is going to be. So what we're going to do, and by the way, we're going to let that play for a second. I want you to see why I love the Sapera stent. When it gets in there, ready, got wire?
Yep, got wire.
Watch the Sapera as it comes in. And anytime you do an IVUS of Sapera, you'll get this boring result. Boringly beautiful. Okay, stop, please. So it's just a perfect zero every time you do that. So what we're going to do is learning from the mistake of not completely dilating before, good, Mango, we took a 7.0 balloon in. We'll put one more Sapera in here, but not get close to the ostium.
Dr. Metzer, I think we just have to switch to the fluoro images.
Go back to fluoro, please. I'm sorry, we got a crew that's a new one for us. They're doing a wonderful job on a two-man team, but let's go to fluoro, please.
Yep, we got it.
There you go. Thank you.
And they're doing a great job. Thank you so much.
Thanks. No, thank you. All right, so this should deploy without any elongation with more predilatation.
Chris, what length is this one?
And then we will put a short, this will be a 6x120. I probably should have gone 150. I got a little wimpy because we're going to put a nitinol stent at the ostium anyhow. And I just don't want to get this close to the profunda because we're going to put a drug-eluting stent at the ostium anyhow. And so whatever's left, we'll put our nav across and measure that. But I want to think together with this smart panel. Should we, before we put our nitinol stent at the ostium, we're all the way across that lesion, which Dr. Jolly got across so beautifully. I think it's probably time, to go ahead, before we put a nitinol stent here, to do our definitive work downstream. Is there agreement amongst the panel?
Panel?
Yeah, I think it's reasonable.
I don't know if it matters either way. I mean, you can stent that. You already have wire across. It wouldn't be detrimental.
Just looking at the head movements, I think you were split on the panel, Dr. Metzer. Some people were like, yeah, definitely. Other people were like, it doesn't really matter if we work through a nitinol stent as long as the sheath is protective. I think some people feel comfortable.
Well, when there's a tie, we win here, because we'll go with what we think. If it's overwhelming, reconsider that. But, again, what I've found before, and there's a little hang up there. I don't like that. What I don't like in general is trying to get through a nitinol stent that we're going to precisely get at the ostium, because sometimes it makes it a little harder to get devices in or out. Let's get our chocolate, small chocolate. Yep. Let me take a picture of the length of what we've done so far.
It's just,
all of which looks good. And then we'll go from there. Dan, how are we doing for time? I suspect we're getting a little closer.
We have one more talk to go, so we can do that and then come back to you to see what you've done for the finals and kind of conclude that way. What do you think?
Why don't you do that here? Yeah, I think so, because right now we're going to do a little work downstream. And while we do that, why don't you do your talk and then we'll wrap it up.
Okay, sounds great. For the sake of time, we'll go back to Dr. Metzger. I think I saw him putting in the most proximal portion.
Yep. All right. Are you back, Dan?
Yes, we're back with you.
Okay. So let's bring you up. What we did was we went down. I feel a little bit like Willy Wonka here because we're using a lot of chocolate, but this is a chocolate balloon down in the teepee trunk. And then you see it open up pretty nicely. And so we got a little bit more aggressive and then this is a long DCB. So we've got Ranger Rick over here and I'm Willy Wonka, and that's a Ranger. And then here's a picture after that in that teepee trunk and the popliteal. We're going to IVUS that when we're done here, but we're pretty happy with that, and the flow was very good down to the foot. And then what we did here is just simply take our Navicross that we already had open and measured that so we could see what length stent we needed. And that's the 40 marks, and then there's a 60 marks up top. So it's unfortunately it's about an 88. And I asked him, we don't have a Zovert PTX or Luvia 88, so we're going to use 100, and we're just going to try to nail that ostium, and that'll be we'll call it a day there. Got any wires there?
Got it. Go for it.
Any more questions or comments
I
from
really
the
wanted
panel?
to, Tomas. I love you, and I was hoping to use just DCB up top, except for the IVUS that you guys just talked about so well. Let's go to fluoro 3.
Watch this.
We're going to have to be very precise here with the ostium of this. We've got really steep on the RAO.
I need more.
Just to bring some spice, the utilization of paclitaxel-based drug coated in the tibial vessel has not shown any significant difference between PTA only.
All right, let's all look together here in just a moment and see if we like this. No crickets in the crowd.
And
Boy, where's the dot? I can't see it.
You got to go in about a centimeter.
You see, okay, smart map. That.
Okay.
There we go. Right there, I think. What do you think?
Yep. That's
All
pretty.
right, it's hard for everybody to see because we're in a configuration. I can't get rid of the smart map for you. But I think I'm going to cine for you here and just compare that. See your dot up there? It's at right above 50. And then I'll stand on fluoro. And I think that's what we need to be. Anybody a naysayer before I deploy?
Yeah, just a little.
Speak now or forever hold your peace. Okay.
Beautiful.
Push it in the end, damn it. All right,
Yeah,
I think we
nice.
got it. All right, so it's back out. Then we'll probably post-dilate it just because it's a nitinol stent.
7 balloon again, I guess.
So
Yeah.
we've got that 7
Yeah,
balloon.
we'll use that 7.
And we'll give you this picture, Dan, and then we'll do a little touch-up work and be done there.
That sounds perfect. Wow.
Yeah, they're trying nice.
Okay.
Well, Dr. Metzer, a truly amazing work as always. It's important for us to remind ourselves this was multi-level, retrograde access, IVUS, pre-angioplasty, woven stent, drug-eluted stent. We got the whole everything on your case. So thank you so much for sharing this incredible case with us and amazing work by the team in Columbus as always. So if everyone can give them a round of applause.
On the teamwork here, you can't see them going around the table here, but it's just amazing. So a great team effort. So thank you all from Columbus. Have a great meeting there.
Thank you. And we want to thank this patient. Maybe we'll see
And
him
my
for
best to
another
PK.
intervention at some point because he's given us so much educational content
We'll do
about
Viva.